Hi, Chodu. So let's talk about the second chapter, that is inflammation. Now, in the exam, again, 1 to 3 questions in the exam. Now, regarding the inflammation, we know that inflammation is a protective response where we are having the WBCs coming out of the blood vessel to the site of infection to kill the pathogen. Now, it can be of acute and chronic. Acute neutrophils are the main cells, and the outcome is self-resolve for majority of the cases. For chronic, it's lymphocyte and macrophages, and the outcome is repair. Now, there are 5 signs of inflammation: rubor, caldera tumor, and functiolesa. Acute inflammation, there are total 10 events we have done. One is the vascular event, where are three, and cellular events, which are seven. The three vascular events: first is vasodilation, increased vascular permeability, and contraction of smooth muscles. The earliest is vasodilation. The hallmark is increase in the vascular permeability. And because the permeability has increased and the plasma is leaked, so inside the blood vessel, you are having thickness of blood, and therefore stasis is happening, slow flow of blood. Now, these vasodilation and increased vascular permeability, they both are caused by histamine. Please remember that. Now, in the cellular events, we have the 7 events. We have discussed this multiple times with the story, so I hope you remember that. Now, first is margination, then rolling, then adhesion, then pavementing, then diapedesis, chemotaxis, and phagocytosis. For your margination, you require endothelin. For rolling, remember selectin. For adhesion, remember integrin. Diapedesis, see, margination will not have anything. It's just a morphological appearance that the WBCs have, covered the entire endothelial cell. But for diabetes, remember the molecule pCAM. For chemotaxis, the best chemoattractant you have to remember, and that is C5a. And for phagocytosis, as I said, that in a phagocytosis, there are 3 steps. The first is recognition. In that, you have to remember the opsonil. Chodu, please listen carefully. The best complement opsonin is C3b. The most abundant opsonin in our body is IgM. But the best opsonin in our body, I mean, sorry, the most abundant opsonin in the body is IgG, because IgG are the most abundant antibodies and they work as an opsonin. But the antibody which is best in functioning as an opsonin is IgM. Okay. And then after recognition, there will be engulfment, formation of a phagolysosome, and there will be finally the killing. Now, when we talk about the killing, in the killing, it can be oxygen dependent, it can be oxygen independent. When I'm talking about oxygen dependent killing, it's a formation of free radical causing the cell death. So, what is the enzyme responsible or required? NADPH oxidase and phagocytic oxidase. And what is the free radical you are trying to make in oxygen dependent killing? OCl negative. तो ये बात याद रखनी है, इसको पूरा रटना नहीं है बेटा. Nobody's going to ask you the steps. They ask you the enzymes and they ask you the free radical. So enzyme is NADPH oxidase, phagocytic oxidase, and the free radical is OCl negative. If you're not able to do oxygen dependent killing, then you do oxygen independent killing, and that is with the help of the granules inside the neutrophils. Now, there are three diseases we have to discuss in this. First disease is chronic granulomatous disease, which is due to absence of NADPH oxidase or phagocytic oxidase. It's an XLR disease, so more commonly in males as compared to female. A child is born with it, and there will be defect in the synthesis of OCl negative. Why? Because there is no NADPH oxidase or phagocytic oxidase present. Gene defect CYBB lead to decrease in the FOX protein. The screening test, directly learn it NBT, and confirmatory is DHR. The second disease which we have to learn is defect in the formation of phagolysosome, Chediac acid. Two things you have to learn. Number one, Chotu, this is AR, autosomal recessive, and XLR, both. So because it is AR, so it is not mandatory that always a male child will be given. Number one. Secondly, there is which gene defect, list gene defect, and thirdly, there will be history of albinism, and fourth, there can be coarse cytoplasmic granules in the neutrophil. Neutrophils have very fine granules, but there can be coarse granules in the neutrophil. Okay. And the third and the final disease which we have to discuss is this LAD. LAD1, it is Roman 1, so Roman I, so integrin defect, delayed separation of the umbilical cord. And LAD2, 2 second CLL Lewis X, it is seen with Bombay blood group. There are some more things we have to learn, like after that, like your Bruton's hypogammaglobulinemia. And here the naive B cell is going to convert into a B cell, and then it will convert into a plasma cell and give you antibody. But for your conversion of naive B cell to your mature B cell, you require a gene called as BTK gene. If this gene is mutated, you never have a mature B cell. And if you never have a mature B cell, You're not making antibodies. So patient is having hypogammaglobulinemia. It is due to BTK gene defect and B cell doesn't mature. It is also an XLR, so more commonly seen in males. Then you have frustrated phagocytosis when the phagocytosis is not complete. Incomplete phase of phagocytosis is frustrated phagocytosis. Nets, when the neutrophil sends the chromatin material outside and traps the pathogen, it increases the risk of autoimmune disorders. It is a suicidal pathway where you have increase in the formation of interleukin 8, and the amino acid which is required is arginine, and it is seen with sepsis. Emperipolysis, when a macrophage engulfs any other cell but does not kill it, seen in uh, non-Hodgkin's lymphoma, Rosai-Dolphin phenomenon, autoimmune hepatitis, and CLL. Whereas entosis, chodu, again a cell is engulfing another cell, but this cell is not a macrophage. So emperipolysis and entosis में इतना difference है. That emperipolysis macrophage है, which is engulfing other cell but not killing it, or entosis के अंदर it is not a macrophage which is engulfing, but a cell is engulfing another cell and not killing it. Then we come on to, मैंने आपको बोला था बेटा कि any inflammatory process that have increased in interleukin 1 leading to fever, and interleukin 6 also can be seen there. Acute phase reactants, they will be seen in acute processes. Some will increase, some will decrease. You just learn the decrease one. ATT, albumin, transferrin, transcortin. Rest कुछ भी पूछते हैं, it will all increase in acute inflammation. Okay. Mediators of inflammation, cellular mediators, plasma mediators. Cellular mediators में preform, newly-form. Preform के अंदर histamine, serotonin, neuropeptide, lysosomal granules. Newly-form, we have these five. And plasma में we have kinins, the bradykinin, and the complement system. Now, in a newly-formed mediator, देखो, first mediator in any inflammatory process is histamine. You know the richest source, mast cell, and the actions also you know. Three actions अपन ने class में बहुत बार याद किया: vasodilation, increased vascular permeability, and contraction of smooth muscles. Then serotonin, it has richest source in enterochromaffin cells. It can also be seen in platelets, but major role is not in inflammation. Major role is working as a neurotransmitter in the GI tract. But if in inflammation it is released, it will work as an histamine. Neuropeptide, that also called as substance P and therefore pain. Lysosomal granules, अभी अपन ने पढ़ा बेटा, primary and secondary. Newly formed nitrous oxide, which amino acid arginine, and which enzyme required NOS. And what are the actions? There are three actions: vasodilation, formation of ONO negative, the peroxynitrite, and because it's a newly formed mediator, so platelet anti-aggregation, not aggregation but anti-aggregation. Arachidonic acid gives you two pathways actually. You get arachidonic acid from the plasma membrane of a cell by which is broken down by phospholipase A2. But arachidonic acid is a very big carbon atom compound. So मैंने आपको बताया था there are two enzymes works, COX and LOX. From COX enzyme you get two mediators, prostaglandin and thromboxane A2, and from LOX enzyme again you are getting two mediators which are what? Leukotrienes and lipoxins. So prostaglandins generally they have the function as histamine only, but because they are newly formed mediators, so they are going to cause platelet anti-aggregation. But if they are individually, याद रखना छोटू बोलना नहीं, please, that if they ask you prostaglandin E2 only, it's pain and fever, and prostaglandin F2, it is only vasoconstriction. So याद रखना छोटे. Normally prostaglandin overall is causing vasodilation, but here the prostaglandin F2 is causing vasoconstriction. Thromboxane A2, vasoconstriction, and platelet aggregation, not anti-aggregation but aggregation. Leukotrienes, B4 will cause chemotaxis. We have endogenous chemoattractants. ILC was the mnemonic. And CD4, D4, E4, vasoconstriction. So leukotrienes are very potent vasoconstrictors. And lipoxins, they are anti-inflammatory. LXA4, B4. Then we have your cytokines: 1 for fever, 4, 6 anti-pro, 5 eosinophil, 8 neutrophil, 10, 13 TGF beta, fibrosis. TGF beta, PDGF, याद रखना, fibrosis. TGF beta and PDGF, fibrosis. Beta, this is the main cytokine responsible for repair in chronic inflammation. ठीक है. Then VEGF, angiogenesis, alpha वाले acute, and gamma, बोला था मैंने, नाम भूल जा रहा है, इसको मत भूलना, macrophage activation, interferon gamma, macrophage activation. Chemokines made up of cysteine, four types: alpha, beta, gamma, delta. Alpha chemokine किसके लिए छोटू? Neutrophil. Beta chemokine, all WBC except neutrophil. Gamma chemokine, this is for lymphocytes. Little activating factor, most important factor of acute inflammation because it can cause vasodilation and vasoconstriction both. Then your bradykinin, but a bradykinin again, same features as histamine, that is vasodilation, increased vascular permeability, contraction of smooth muscles, plus pain. तो पेन के लिए तीन मीडिएटर्स हो गए, सब्सटेंस पी, ब्रेडिकाइनिन एंड पीजीई2. बेस्ट क्या है? पीजीई2 बेस्ट. कॉम्प्लीमेंट सिस्टम, टू pathways of activation, or classical alternate. Classical में antigen antibody complex will activate your C1. So it's called an immune pathway. And C1 to C2, C2 will go to C4, C2 and C4 will activate C3, and C3 will activate C5, and finally this complex is formed. C5b, 6, 7, 8, 9. Alternate में no immune complex, direct activation of C3. The rate limiting step of complement system activation is C3 activation. What are the actions of complement system? Opsonization, chemoattraction, cell lysis. For opsonization, it is C3b. For chemoattraction, it is C5a. आने वाला आजा आजा आजा. And cell lysis, it is C5b, 6, 7, 8, 9. This is membrane attack complex. For a chronic inflammation, the hallmark feature is tissue destruction. Which WBCs you are going to see? Monocytes and lymphocytes, I mean the mononuclear cells. And because it's a chronic inflammation, major damage, so you'll always have repair. Cells of chronic inflammation, the best cell is macrophage. We know macrophage can be activated two types, classically, alternatively. Classical activation, but what is the function of a macrophage? Fight. So it's a pro-inflammatory macrophage you'll make, M1. And what is the interleukin required? Interferon gamma. Whereas M2 macrophage, it's alternately activated macrophages. It is going to help in repair. And the interleukin required are 10, 13, and TGF-beta. Different kinds of macrophages and different cells of the body, like brain, microglial, or jitter cells, lungs, dust cells, or alveolar macrophages, liver is Kupffer cells, kidney mesangial cells, spleen, littoral cells, placenta Hofbauer cells, bone osteoclasts, and synovium hepatitis type A synovicyte. Lymphocytes we'll discuss in the next chapter. Eosinophil 1 to 6% of WBCs, and I told you chotu, acute chronic kaisa hi hone do, parasitic infection, eosinophils. Allergy also eosinophils will be there, basophils the least, again in allergies. Then your granulomatous inflammation, four components of granuloma, central necrotic core, epithelioid cells or activated macrophages, your lymphocytes, and the fourth component is giant cell, the giant cell outside. Now, why would a granuloma be formed if the pathogen is too dangerous? Then do you remember I gave you that story where the army will come, surround it, and kill it? That's your granuloma. Now, granuloma can be of multiple types, like an immune granuloma. Immune granuloma matlab granuloma with lymphocytes. Non-immune or naked granuloma means granuloma is there, but there is no lymphocyte. Then caseating granuloma means granuloma with caseous necrosis, seen with TB. And non-caseating granuloma means granuloma without caseous necrosis, seen in sarcoidosis. Special types of granuloma, stellate, star-shaped. What is special in it? One is the shape, star. Second, these things are neutrophils, and it is seen with cat scratch plus LGV. Duck's granuloma, cerebral malaria, Plasmodium falciparum. Donut granuloma, Q fever. And eosinophilic granuloma, central eosinophilic infiltrates, Churg-Strauss disease. Giant cells, necklace-like Langhans. Central nucleus, Teuton. Anywhere, foreign body, haphazard. These are the images. This image have come in the exam. Repair, regeneration, scar formation. If you get what you want, regeneration. If you got something else than what you wanted, scar formation. Depends on extent of injury. If it's deep, always scar. If it's superficial, then depends what kind of cells are damaged. If there are cells which are regenerative cells, then regeneration can occur. If the cells are non-dividing, always scar formation. According to regeneration, we have three kinds of cells. I've explained to you before also in the classes. Labile cells, continuously dividing. Stable cells divide only on stimulus. Then your permanent cells never divide at all. So labile and stable cells in a superficial injury can give you regeneration. But permanent cells, they will always show scar formation. What is scar? Made up of three things. First, angiogenesis, then granulation tissue, and remodeling. What is the granulation tissue? Four things. Your WBCs, your macrophages, your collagen, myofibroblast, and the vessels. Vessels, myofibroblast, collagen, and leukocytes. Now, when you're repairing, sometimes the repair goes beyond it. You need repair till here. So what you do, remodeling and gelling of these things, these four cells, it also requires remodeling. So which enzyme will be causing remodeling, gelling up of these cells and removing anything extra? MMP9, matrix metalloprotease 9. What is the metal required? Zinc. And what is the vitamin required? Vitamin C. Healing, primary, secondary. But a secondary healing because the wound is damaged. The margins are damaged. So it's unclean. So always scar. But primary healing may because the margins are proper. So if it's a superficial injury, we can have regeneration. If it's a deep injury, we'll have scar formation. The cell which is responsible for scar formation is myofibroblast. It causes wound contraction. Now you just have to learn this on the fifth day. People will not see it. On the second week, you will get the strength because collagen is going to be there. Scar forms at the 28th day, where collagen 3 is replaced by 1. And the maximum wound strength come at the end of third month. I hope you remember that, we discussed that. In the pathological aspects of repair, you just have to talk about the hypertrophic and keloid. If it's a corneto-cone, it is hypertrophic scar. Matlab, it's a raised scar, but within the wound boundary. Keloid raised scar even outside the wound boundary. This is genetic. Most common site is sternum, earlobes, umbilicus. For hypertrophic scar, what is the outcome? Self-resolve. For keloid, intrakeloidal injection of triamcinolone. That is it with the chapter of inflammation. 1 to 2 questions you can expect in the main exam. I hope this quick revision of the entire thing helps you in having a feeling कि नहीं नहीं ऐसा नहीं है that I have forgotten it. I now it's revised. Now you can sit with this chapter for some time. It will take maybe an hour or 1.5 and you'll be okay with it. See you in the next. Thank you.